Good evening. This is Deep Dive with Dr. Tracy, and I am your host, Dr. Tracy Pearson. I am grateful that you've joined me this evening. If this is your first time watching, welcome. If you've seen this program before, welcome back, and thank you for coming back. How's your week been? I hope it's been a good one, if not a great one. I am super excited about this show. We have 3 phenomenal guests this evening, 3 of them. And they are gracious to join us. And we're going to be jam-packed with information, so I need to get to it. For most of my life, I have taken for granted that I can see a doctor if I need to, and that they will be there to provide me with treatment. I trust doctors. I treat doctors like experts. Yet, I've had to push to get answers in the past. I had one situation where I knew I had a medical issue. And I went through maybe 6 physicians to try to figure it out. I'm what the medical profession sometimes calls a zebra. It's a term in the medical field which sort of means if something is wrong, it's the most unlikely medical diagnosis, not the most common one. I advocate for myself and ask really probing questions that can sometimes challenge some doctors to think differently. But just like I went to law school and expect that I have more knowledge and experience than someone who didn't, I know that doctors have more knowledge and experience than I do about the science of the human body. Prior to the pandemic hitting, I moved to Los Angeles. And as I shared on a recent Deep Dive podcast, when I arrived at LAX, I was a little over 130 pounds heavier. You don't believe me? Let me show you. That was me on my wedding day in 2015, and that was me this month. I had been overweight my entire adolescence and adult life. I had tried everything. Doctors labeled me lazy. I had given up and accepted my fate, but on seeing my new doctor in Los Angeles, it turned out that I had a condition, and with very simple treatment, I lost all of the weight in around 9 months. It's been quite an adjustment, trust me. But finding the right doctor on the right day mattered, and not a moment too soon, because one of the risk factors that makes it more likely you might die of COVID is being overweight. I also have asthma. It was late onset and not caused by my weight. It changed my life considerably. I'm still pissed off about it. I'm pissed off about the weight thing too, but that's a different show. So I have shed the weight issue, but I still carry that heavy burden of having asthma, which is also a risk factor of dying of COVID. I know what it's like to not be able to breathe. I know the pain that an attack causes me at the time, where I'm unable to expel the air that my body is fighting to take in, and how frightening it is for my body to refuse to do what it has always done unconsciously. I know the experience of hypoxia, when your body isn't getting enough oxygen. I know what it feels like afterward, where muscles you didn't even know you had hurt, and you feel exhausted because they were working to try to make you breathe. In those situations, I rely on my ever-present inhaler and my backup nebulizer. And I know that a dose of some steroids can get me back on track if I can be seen in an emergency room. But it's still frightening. Viruses are little nasty things. Unlike bacteria, they don't respond to antibiotics. Your body has to mount a defense and to fight the damn thing off. It has to recognize it has an invader to do that. It doesn't treat everything as an invader. If your body hasn't seen that virus, it's novel, then it can replicate in your body and overwhelm it before your body can mount a defense. And then the defense is vigorous, flooding areas of your body like your lungs with cells to mount an attack. Enter coronavirus 19. I was able to stay home to quarantine myself away from others, and I still am, but for very few exceptions. My doctor has been clear. I'm at high risk of intubation. Now, not always, but it seems that the stories that I read in reputable newspapers reflect that if you're intubated and on a ventilator because of this virus, it's likely you aren't coming off. It was late December 2020, early January 2021 that I started reading and hearing stories about rationing of care. Hospitals were overwhelmed. There was no vaccine yet that could lessen the blow. I was at high risk. I had a condition that challenged my ability to survive this disease if I got it. And I had a stunning realization that though I had finally beaten the weight problem that people said I would die of eventually, I might die anyway, and that these things I had taken for granted most of my life, doctors, nurses, equipment, might not be there to see me through this nightmare. And I'd be doing it alone. But for an overworked doctor or nurse covered head to toe in protective gear, because my husband wouldn't be allowed to be with me. I recently had an operation and unexpectedly ended up in the ICU, and my husband couldn't be with me the entire time, mostly because of COVID. And when he wasn't, I was helpless. It was awful. Now, granted, I was awake, and I don't think the IC is used to having people who are awake and conscious and talking in their unit. So that was a challenge. But I remember having lines going into each arm and staff putting a tray of food on a table just a bit away from me, and it taking everything I had to pull that tray forward, to open these containers, and to cut the food and feed myself. So if I ended up in the ICU, I'd be helpless and at the whim of people who worked there, some of which were better than others. When that damn vaccine came out, I took it. Now, I had, of course, being a zero, what would be considered a normal negative reaction to it. My blood pressure dropped. I planned for it and worked with the providers to manage that reaction to future doses. I took the second dose. I took the third dose. And I'll take every dose after that if it means that I won't suffocate to death or die with a tube down my throat because of this virus. A tiny thing that doesn't care about who you are. It doesn't care who you voted for president, whether you're rich or poor, whether you live in California or Tennessee. Its sole purpose is to replicate and survive. But I had to come to the realization that not everyone is like me. And we're entering, year 3 of this pandemic? Now, I'm in LA, and in LA and in New York City, we were hit hard initially. The rest of the country shrugged. Now the rest of the country is suffering. And again, I'm hearing and reading stories about rationing of care, about litigation over issues of whether to remove ventilators, transplant patients choosing not to take a vaccine that millions have taken. And because they aren't taking it, they are making themselves ineligible for transplants, almost guaranteeing their death. All of these issues fall within an area called bioethics. So I have a lot of questions. I needed to talk to people who understood these issues, experts. And it just so happens tonight I have 3 of them. Our first guest this evening is Jennifer Needle. Dr. Needle is an associate professor of pediatric critical care and bioethics at the University of Minnesota Medical School. Hi, Dr. Needle. Welcome to Deep Dive with Dr. Tracy. How are you?
Hi, Tracy. Thank you for having me.
So, what exactly is bioethics?
So bioethics is a field of study in medicine and a practice that uses standard basic moral principles that we all understand to help resolve some of the complexities and conflicts that we see in medicine. And while it may sound dry, I think most people don't realize that there are truly bioethical issues inherent in almost every single medical interaction. This was something that we have been talking about well before the pandemic, but certainly has raised its meter of what people are paying attention to because of words like rationing, and people's concern about individual rights versus community rights and individual responsibilities. And this is not a new topic. This is not a new area that has been present in medicine. But I think with the advent of the pandemic, social media, people sharing their stories, it certainly has risen to the level of people paying more attention to it.
Has it always been part of the curriculum of medical schools, or is it a somewhat newish field or something else?
It's certainly not a newish field, and some medical schools teach it more distinctly and more eloquently than others. I think it's very much an on-the-job kind of training for most medical providers. You confront issues that you don't realize have an ethical lens that you didn't even think about. We certainly teach how to follow patient-directed orders, who qualifies as someone's surrogate, how do people make decisions, what happens at the end of life when there's conflict. In my field of pediatrics, we talk about when is an adolescent able to exert their own preference if it's in conflict to that of their parents. There are some constant themes that we address in bioethics and that rise to the level of seeking a bioethics consult, but it's not something you can learn in a PowerPoint presentation in a medical school class. It's something you learn when you are sitting across from a patient and you say to yourself, my goodness, I'm not really sure how to resolve this gray area.
I didn't take biochemistry, thank goodness, and I'm very glad about that. And I didn't take bioethics either. How does bioethics play a role in patient care, and why do I care about it as a patient?
I think the one thing that's important for patients to understand is that bioethics serves as a service to ensure quality, fair care for patients and for providers. We are an objective third party who is asked to enter a patient-clinician interaction by either side. So we receive consults from families, we receive consults from clinicians, healthcare administrators. Our goal is to utilize a standardized framework of moral principles on every single encounter that we're asked to address. And the goal here is that if it's standardized in the way we look at that case, that adds to the element of justice and equity in how we help resolve a conflict. So go ahead. Sorry.
No, I was thinking of, okay, so we're in the hospital. How would I contact somebody to get a bioethics consult if I'm a family member of a patient?
Well, certainly it is the more savvy families that know to ask. I think families that really are concerned about a conflict may ask for patient relations, and then oftentimes we will hear about it from them, or they will ask their provider, is there anyone else that can help resolve this issue? And we would hope that clinical providers would say, yes, in fact, we have an ethics consult service and we can engage them in helping us resolve this issue.
Now, I contacted you because you were quoted in an article about a family that was litigating over an issue related to the removal of a ventilator. And I want to make it clear to everyone watching that you weren't involved in that case. But like I reached out to you, you had been contacted to help a journalist with some information. And so hospitals are being faced with scarcity of resources, both equipment and human beings being able to operate that equipment. And, you know, I want to give folks a picture of what it looks like to make that decision, because we haven't seen this before in the United States for average citizens. I mean, we're not talking about mass casualty events that people have seen portrayed on ER, you know, where a building has collapsed or a plane has crashed and you're seeing these actors walking around putting tags on people's gurneys, colored tags. You know, that to my mind is the scarcity of resources calculation on TV. That's not what we're talking about. And so I want to have some understanding of what this looks like. So I have sort of a hypothetical for you. And I want to be clear with everyone, this is hypothetical. We're not basing it in a real scenario. And we're going to use me as the example, since I shared a lot at the beginning of the show. I come into the hospital, and despite having done everything I could to not contract COVID, we try regular oxygen. We move up to the CPAP machine. And the cytokine storm is raging in my poor asthmatic lungs, and I need ventilation. But there's scarce resources, either because there's one ventilator or there's limited staff or space to operate that ventilator. And another patient comes in who isn't me, but also needs that ventilator. Under what conditions would I not get that ventilator, and under what conditions would I?
So I want to be pretty clear that despite the fact that the language such as rationing has been thrown about, we are not currently in most places in the United States in a situation where we have two people competing for one ventilator. When we talk about scarce resources, we talk about three things. We talk about space, we talk about staff, and we talk about stuff. So what that means is, do we have ICU beds? Do we have people to staff those ICU beds? And do we have the equipment that we need in those ICU beds to take care of patients? Currently, the largest difficulty is actually with staff. During the height of Omicron, there was a tremendous amount of healthcare workers that were actually out of work because they were, in fact, themselves infected with COVID. And we were working with scarcity of resources related to staff. But back to your question, we would not be at a point where we would be determining whether you or the person who comes in after you would qualify, so to speak, for a ventilator until we were at what's called crisis standards of care. We are not, there are a few states during the height of Omicron that declared crisis standards of care, but in general, we are in what we would call contingency standards of care, meaning that there are limitations, but we are not rationing one ventilator between two people. But let's say we were, because I think that's something that's really critical for the public to understand how a decision would be made under those circumstances. And we went through these intellectual exercises at the beginning of the pandemic when we were highly concerned that that may become a reality. And we established some basic ethical principles of how to determine who receives scarce resources. First and foremost, I think people need to understand that race, age, gender, orientation, vaccination status versus non-vaccination status in and of themselves are never an ethical criteria for determining who deserves or would qualify for scarce resources. Now, when I say in and of themselves, as a single isolated demographic, we don't decide that way. But there are things that confer a higher likelihood of survival with the use of those ICU resources. So the underlying principle of how we decide who receives treatment is to maximize the opportunity for someone to survive that acute ICU stay. So you have asthma, which is a risk factor, and the other person has congestive heart failure and diabetes and is 25 years older than you. We would undertake a calculation of who is more likely to survive their acute infection with COVID with the use of that ventilator. So a risk factor or a factor in, age or any of those things alone are not enough for someone to say, okay, we would give it to person A as opposed to person B. I think there's a lot of fear that there's someone sitting out there making these decisions about who deserves a ventilator. And I think it's really important for the public to understand that those decisions are made based on medical data from the hundreds of thousands of people who have required ICU level care over the last 2.5 years.
That's helpful to understand. Now, when we talked initially, we were discussing the circumstances of wanting to remove a ventilator, and you told me that that wasn't the story, that the story was much larger than that. What does the public need to know?
Well, I think the concerning thing now is that the last 2 years, we have seen an escalation in the mistrust of medicine, the same way we have previously seen mistrust of government or mistrust of, economic industries. And for some reason, people believe that they now know more than most medical professionals, in the sense that, no, I don't want this blood thinner. I read that I should ask for this blood thinner. And I think the concerning thing isn't about the case that makes it to the newspaper or the person who posts on social media all the wrongs that occurred to their loved one in the hospital. I think the really critical story here is the recognition that healthcare providers are doing the best they can with what they know and what they have at the time. And the level of mistrust and denial of certain medical treatments, but demand for other ones, is creating a very significant crisis within healthcare itself. Over 20% of the healthcare workforce has left the healthcare workforce since the beginning of COVID. And I won't necessarily posit that that is all because of treatment of healthcare professionals by those who don't trust science, but it certainly is a contributor in many ways.
Now, one of your specialty areas of interest is in palliative end-of-life care communication in critical illness. So I want to shift a little bit. You conducted a study that was published in the Critical Care Medicine Journal in 2012, where you were examining, and this is going to be a mouthful, the influence of personal preference for life-sustaining treatment on medical decision-making among pediatric intensivists. For the non-science folks listening, I'm going to ask you 3 questions. Who were you studying? What were you trying to understand, and what did you find?
So the shortened, non-technical version of that study that we did was really to look at how pediatric ICU doctors make recommendations and how they decide what to offer families when end-of-life situations are being approached, and how that relates to their own personal preferences for what they would want under similar circumstances. I think doctors are people. Doctors are people who are mortal and understand that they too themselves at one point may be facing an end-of-life decision. And they see things that people choose for their families that they would never choose for their own families. And oftentimes our own personal bias introduces itself in a doctor-patient exchange. I think it's unrealistic to expect individual human beings who practice as physicians to not have their own preferences and beliefs about what they may or may not think is the right choice. What I wanted to understand was, do those biases, do those personal preferences lead to bias in what they would be willing to offer a family? And we looked at a scenario that was a very value-laden situation. So it was a child who had a severe spinal cord injury in a car accident. So they would be requiring a ventilator for the rest of their life and unable to care for themselves. So this is a scenario that we posed to pediatric ICU physicians where there's no clear practice standard. unlike COVID, where we have really good protocolized ways of managing the disease. But there's no clear standard for whether or not you would offer this family a tracheostomy and ventilator, whether you would offer them to just proceed to palliative care and create a comfortable death for a child under these circumstances, and whether you would offer either of those and whether you would recommend either of those. And what we found was that, in fact, people's own personal preferences for what they would want at the end of their life did influence what they were willing to offer and recommend to patients and families. So I think the take-home message here isn't that physician bias enters into every doctor-patient encounter. I think the take-home message here is that we should be aware that we have our own personal biases and that we need to spend a lot of time talking to patients and families about what values they hold with relation to illness, disability, and death, and help incorporate their values with what we know about the medicine to then decide what we would offer or recommend based on what is important to the family.
Based on your experience in bioethics, how, in practical reality, how do bioethicists that possibly sit on a committee in making recommendations or in evaluating these situations, how does the personal preference issue play a role in those determinations, and how do you mitigate against it based on what you found in your study? And I'm asking you to sort of go a step further. Sure. And understanding that you haven't necessarily studied this, but how do you mitigate for that in that situation?
So the one important thing you said was committee. And I think one of the clear benefits of an ethics committee is that it's represented by various points of view. As I said at the beginning, we use a very standardized framework for how we look at an issue. We ask the same questions of every consult and conflict that we get so that we aren't overlooking someone's religious convictions for one case or not taking into account their history of hospitalization and prior illness in another case, so that we can incorporate all the information. And the other really critical thing for the public to understand is that ethics committees do not make medical decisions. We are asked to offer an opinion about whether or not medical treatment A or medical decision B are permissible. But we do not say, yes, take that patient off the ventilator. We say to the medical team, under these circumstances, it's ethically permissible to take the patient off the ventilator. And then it is the medical team's decision, along with the patient's family, to either do that or not. So there certainly is an effort to incorporate into every ethics committee a variety of specialties, backgrounds, races, genders, religious viewpoints. Quite regularly when our committee meets, we will bring in other people that we think are particularly relevant to this particular case. If it is a religion which is not strongly represented by people on our committee, we will ask for an imam or a rabbi to join in the consult so we can get a better understanding of how the beliefs of the family interacts with the medical environment and how we can utilize that information to offer a recommendation. I won't pretend to tell you that there's never bias, but I will suggest that I have yet to come across a situation where an ethics committee meeting did not have a robust pro and con discussion prior to coming up with a recommendation.
Now, is having an ethics committee a legally required thing at each hospital?
Yes.
And is that a federal requirement, are you aware of, or is it a state requirement?
It is a JACO requirement. So the Joint Commission requires that there is not every hospital has to have a committee, but every hospital has to have access to a committee for particular cases.
And I know that med review records or discussions are considered to be confidential. Is it the same way with these bioethics committees?
Well, the bioethics consultants have access to medical records. And so the standard practice, let's just use a scenario of the medical team thinks it's time to take the patient off the ventilator and the family disagrees, since that is really kind of the premise of many of these conversations. An ethics consult would involve talking to the medical staff and talking to the patient's family, and then figuring out, based on the medical information and the information received from the family, why do they feel it's important for the patient to stay on the ventilator? What about the patient coming off the ventilator are they so opposed to as far as their values? What do they understand? And oftentimes the role of an ethicist is to help bridge a communication gap between a medical team that has felt very strongly that information has been shared and a family who has not received that information in the way the medical team believed they did. And so we can also facilitate communication. We can make recommendations for additional information to be given to the family. So we don't just get involved to help render a recommendation to do A or B. Oftentimes we're there to help resolve a conflict that isn't necessarily to the level of a decision needing to be made, but it seems as if the team and the family are not on the same page, and we can help as an objective third party understand where that gap exists and perhaps how to fill the gap.
Are those records, are the bioethicist records, notes, let's say, of meetings, are those confidential, or are those considered to be like any other service that the hospital provides and part of the medical record?
So bioethics consults are part of the medical record. Not every patient consult that is received by a bioethicist goes to a full committee. Many times there are, as I said at the very beginning, there are ethical issues inherent in almost every aspect of medicine. Oftentimes we get called because they don't know if the wife or the daughter are better surrogate decision makers for the patient. We help resolve that. That's not something that goes to a committee. We can help the team understand who is best suited to speak for this patient's best interest. The highly volatile, controversial decisions will go to a full committee, and those recommendations from the committee will be incorporated into the medical record.
Now, I ask a lot of questions about my own care. Being a zebra, I've had to learn to do that. Is there anything that a patient's family shouldn't be afraid to ask or should ask when they're faced with this situation where, in the scenario you're giving where providers want to end life-sustaining treatment, let's say?
Is there anything they shouldn't ask?
That they shouldn't be afraid to ask, or that they should ask, in other words. During when they're working with a bioethicist, let's say.
Sure. I mean, the unfortunate reality is that we don't tend to get involved until there is conflict. And so, one would hope that there's really good communication between the medical team and the patient or family, which part of the reason there has been so much difficulty in COVID is, as you spoke about, family members are not allowed for an active infected COVID patient to be in the hospital. So communication takes place via iPad, via telephone. And it's very different to hear someone say to you, Tracy, your loved one is very sick, over the phone, as it is for you to be standing over your loved one at the bedside, watching what it looks like for them to be on a ventilator, watching what it looks like to have that ICU experience. And so I think with COVID, a lot of the difficulty is that people are not witnessing this experience of their loved one. And the way that you can portray the situation over the phone is very challenging.
Now,
yeah.
go ahead.
No,
go.
I think the point is that people should feel empowered to ask any question they have of their medical team. They should feel empowered to utilize information that they've received and ask questions. And they should feel empowered, if they feel a conflict, to escalate things beyond their clinical team, but not in a sense of an antagonism, but really in a sense of, we don't seem to be understanding each other or on the same page. We need someone to help facilitate that. And we know that conflict at the end of life usually doesn't just start at the very end of life. There has been conflict inherent throughout a patient's hospital stay. And so we encourage providers, if they feel that there's the potential that worsening conflict will develop with this particular patient or family, that we should be involved as early as possible so that we can help mitigate any future conflict. And we would say the same to any family or patient who felt that they were not being heard, that is the role that ethics is there to provide.
Is there anything that providers can do better when it comes to communicating with patient families?
How long do we have to talk?
Give me the top three.
Okay. I think number one is taking the time to have honest, direct communication about someone's condition. I think oftentimes we use words like "we hope for" or "we'll wait and see if." And if you're a person without medical experience who's in crisis because your loved one has now been admitted to an ICU, when someone says to you, "we hope that," you hear it as, well, that's what's going to happen. So I do recommend that while we want to give families the opportunity to hope for a good outcome, if we don't anticipate one, we should be very direct about that from the beginning so that families can prepare. I think making sure that for non-English speaking families or families that have limitations for their opportunity to be in the hospital with their family members, they don't have transportation, they can't take time off work, we need to make more efforts to ensure that those people get information. As I'm sure everyone is aware, most of activity in the hospital happens from 7 a.m. to 7 p.m. And then there are people on at night who may not be as familiar with the longitudinal care of that particular patient. And so if we have a patient's loved one who doesn't come in until 10 o'clock every night because they have to work to support their family, and there's no one there that could really sit down and have that long conversation with them, it tends to lead to miscommunication. So, I don't want to make it sound like doctors are all terrible communicators, because every doctor is in an ICU doing the best they can to save people's lives and help their family cope with the critical illness their loved one is facing. But I do think that honest, straightforward, direct communication about what they're up against from the beginning of the hospital admission would be helpful to mitigate things as time went on.
Dr. Needle is an associate professor of pediatric critical care and bioethics at the University of Minnesota Medical School. I want to thank you for taking the time, and I hope that you'll agree to come back again soon.
Absolutely. Thank you, Tracy.
Thank you. Okay, folks, so we're rolling right along here. My second guest this evening is Dr. Alyssa Burgart, a board-certified pediatric anesthesiologist and bioethicist. I got that out that time at Stanford University. Welcome to Deep Dive with Dr. Tracy. So first, having had the opportunity to listen to Dr. Needle, did you want to add anything to what she said?
Dr. Needle is things that she discussed in her segment and the communication issue, hours of training in terms of negotiation-centered communication. And as she said, oftentimes an ethics consult for a team, and they try to figure out, how can we help these communicate better with each other, to really try to figure out, and how can we make sure that we can help this family. Such a tragedy.
I am hearing your sound go in and out. I am wondering if there's an issue with your earbuds. We have that happen sometimes. That's okay. Sometimes we have that happen.
Let's try something.
That's okay. This is live and this is what happens. No worries. Can't hear you. This is the point at which I put on a top hat and I get my stick and I do some tap dancing. No sound. If you go without earbuds and just talk, I'm wondering what it sounds like.
What happens?
Oh, okay, that'll work.
Okay. Thanks.
So let me give you an opportunity to sort of recap. Is there anything that you heard that you wanted to respond to?
Dr. Needle's spot on. I think we're having very similar experiences in California to her experiences in Minnesota. Certainly there's a lot of variation about how various hospitals organize their ethics consultation services, but generally speaking, I think we're unified in doing our best to help clinicians and help patients and their families navigate really just some of the hardest times of their lives.
Now, the question that I start out with you is the Hippocratic Oath is what folks think of when they think of a doctor's responsibility. And as you know, that document is much longer and archaic, coming from Hippocrates' time. But it's sort of been boiled down to do no harm. Now, the AMA has a statement of personal responsibility that is what I think of when I think of the modern Hippocratic Oath. Would that be accurate?
I think physicians take their personal responsibility for patients incredibly seriously. So I think that's an appropriate way to think of the ways that Hippocratic Oath and sort of our responsibilities as physicians have evolved.
Now, I actually have a graphic of that AMA statement for reference. It's entitled "The Declaration of Professional Responsibility: Medicine's Social Contract with Humanity." And I guess, and hopefully you can see you've probably seen it before. You're probably familiar with it. It's got a list of it looks like 9 promises. And I guess I want to understand the intersection of these promises, or this promise, and bioethics.
I am not familiar with this document, so
that's okay.
And I apologize. I really can't see it very clearly from this vantage point. But generally, we think very strongly about the dedication that we have for each of our patients and ensuring that our patients are getting really the best care possible as we move forward in taking care of them. And I think this is what leads clinicians to make a lot of decisions, is trying to figure out how I really help this patient that's in front of me, and how can I ensure that that I can go home at the end of the day and feel confident that I have done the best I can to help each and every patient live their best life.
And that sounds consistent with what that promise is to take care of people who are sick, to give people, allow people to have their dignity. And some of the other promises that are made in there, one of them is to work with other doctors, to work together collaboratively. I always think it's interesting that needs to be in writing. But, I can see, why they want to make that clear, given how compartmentalized the medical profession is. And how, I've had experiences like other people have about with different specialists and who has decision-making ability when it comes to certain methods and care. Now, I want to dig into some of your specialty areas, which I understand are transplantation and disability rights. Is that correct?
Yes, that's correct.
Okay. So now there's been some headlines about folks on the transplantation lists at various places being ineligible due to not being vaccinated for COVID. In fact, hospitals in Ohio, Colorado, and Boston have deemed patients ineligible because they wouldn't take the vaccine. Can you help us understand some factors that go into deciding whether someone is eligible or ineligible to receive a transplant?
Definitely. Transplant selection is something it's pretty complicated and it's challenging. The United Network Organ Sharing Group specializes in a number of things to try to figure out how can we ensure that the organs that are available, which are an incredibly limited resource, go to the patients who are most likely to benefit from them, most likely to survive for a long period of time with, again, the quality of life. And by definition, transplant patients, as you mentioned in your introduction, these are folks who oftentimes are on the brink of death when an organ becomes available. So it's an incredibly important and delicate time to manage. So in terms of figuring out who is a candidate, frankly, I work with a lot of transplant surgeons. I'm a trained anesthesiologist. We love to transplant people. It's one of our favorite things to do. We love seeing patients do well after a transplant and be able to really benefit from that gift of life. And so I think that what all of us who work in transplant would love is for there to be enough organs for every patient who needs them. And unfortunately, because of that limited supply, we have to say, well, what we call it organ stewardship. How can we ensure that the organs that we do distribute to patients are cared for? How can we partner with those patients to ensure that not only are we offering them the best medical recommendations, but again, it really does depend on that trust between the physicians and the nurses and the social workers and the dietitians and all the people who are on the transplant team working with that patient to ensure that not only is the patient getting that benefit, but the organ is kept in the best possible to last for a very long time. On the vaccination issue in particular, the idea that you need to participate in a vaccination program is not. Transplant patients in general are expected to have a lot of different vaccinations in terms of basic childhood vaccinations, vaccinations against other diseases that we've seen for. And so COVID is just the newest vaccine to be part of this conversation. Now, the federal government and the federal groups that help with organ distribution don't actually specify COVID vaccination is a requirement. It is something that is strongly recommended in the guidelines for transplant patients. So what we've seen in these cities where we've had people who have been denied listing for transplantation because of COVID vaccination status, there are certain hospitals who have made that part of their criteria. They say, this is one of the many, many things that we're going to ask of you. There are some transplant programs that are not as rigid on and every one of these requirements. And so there absolutely across the country is some variability.
And so one of the questions that I have in relation to that then is, one of the things that I've noticed with the COVID vaccine is with the EEOC, when it comes to employment, they've sort of defined the religious exemption as, your sincere religious belief, not your membership in a religion in particular. If it were the latter, it would be, there's really only one religion that prohibits the use of vaccines. It's the Reformed Dutch Church. All of the other religions don't have a prohibition to that. But because it's your sincere religious belief, it's a little different. So if your religion doesn't permit it, if your sincere religious belief doesn't permit you to have vaccination, is it going to be an exception in those programs, do you think?
It's a great question, and it truly would depend on the individual selection team at a hospital. And that, again, is a group that is a little bit less regulated than some other aspects of transplant care. And so this is oftentimes a group of people who are all part of the transplant process, who know the patient well, who've helped evaluate the patient for their candidacy, and to get together and review the patient systematically and say, wow, where are we from a disease perspective? Where are we in a social perspective? Are there any, things that we need to be aware of? And if a patient's religious beliefs would seriously conflict with the ability for that organ to survive within this patient's body, it's understandable and important that would be a factor. However, if this religious objection to whatever this aspect of care is not likely something to impact whether that patient will be able to have a good outcome with that organ, then it wouldn't make sense for that to be included. So I think it's really important to realize that each of these patients who are considered for transplantation should be getting a really holistic, well-rounded view of them, not only as a patient, but also as a participant in their care.
I guess, can you explain to me then, I want to make sure that I understand. What role I've heard the word UNOS, organization, I think it's called UNOS. What role do they play if each hospital sort of has their own thing and it's not regulated or highly regulated?
So there are many aspects of transplant that are highly regulated. It's the selection process that is a little bit more gray. Part of what UNOS is doing is they're the group that's saying, these are the organs that are available. They're working with distributed teams across the country to say, who's on the list, who's not on the list? Is there an organ that is geographically close enough to this patient and it's from a patient who is the right weight and age and has the correct organ that this patient that needs a transplant is looking for? So those are some of the things that are being regulated in that process. There's it's the list of kind of who gets that priority once they're listed is part of what is really highly regulated.
Now, in hearing sort of how this is described, I can see how someone might find that the valuing of certain things over others can make this a bit messy. And so what I am trying to understand is, that duty to care for the sick, and bioethics as a field, and the decision to remove someone from a list if they aren't vaccinated. How do people come to terms with these ideas that seem to me to be in conflict?
I haven't been in this particular situation, and so just as yourself, I've learned about these cases by reading about them in the news. My sincere hope and my expectation is that these clinical teams probably work pretty closely with these patients to try to establish that level of trust to ensure that the patient was willing to participate in kind of the full complement of care for a transplant. Getting a transplant means, obviously the goal is that the patient doesn't die of their end stage disease, but it is swapping out an exceptional amount of care that patient will still need in order to really get that benefit. And so when a transplant team hears from a patient, I don't trust you on this critical information, it understandably leads the team to say, are we missing something? Are we going to be able to have this really intimate long-term relationship in which I can give you the recommendations to help you live longer? Will you? And oftentimes I think that's a huge issue involved is, again, getting back to that communication issues that Dr. Needle brought up. This is a key factor. I doubt that these teams came to these decisions lightly. When I have been in these selection committee experiences in other places, they're really difficult.
And I can see how that is. It seems like it would be very difficult, and you're working with this patient over a long period of time. I want to jump to another area of specialty for yours, which is disability rights. How do you see bioethics and disability intersecting when it comes to COVID?
It's everywhere. I think what we see what we've seen throughout the pandemic, and certainly your experiences that you described really touch on that significantly, which is that I think we've heard the message many, many times throughout this pandemic that the lives of elderly people and the lives of people who are living with disabilities are somehow less important or less valuable than so-called healthy people. And I think this is a huge mistake. I think that we need to ensure that we are honoring the inherent human dignity of every single person. And whether, for many, it's just that we're not disabled yet. And I think that that's something also that many people don't think about, because if they're not thinking that they have someone they love who is elderly or someone they love who has a disability, I think there's a real disconnect in understanding about the ways that society is constantly harming people who have disabilities.
I was personally horrified when I've been personally horrified many times during all of this, but I was personally horrified when I heard that the CDC was relaxing standards among healthcare workers who were COVID positive. I had a surgery that ended up being rescheduled, and I was sitting there trying to figure out exactly how I was going to manage not having someone who would be COVID positive wearing a mask working on my case. And under the ADA in California's more comprehensive equivalent, FEHA law, I felt that I was in pretty good position to ask for an accommodation, but they shut down the ORs and it was rescheduled. But I still have this little bit of concern. And I guess what I'm wondering is, what are your thoughts on the CDC and in relation to bioethics of these decisions to roll back protections, especially as they pertain to people with disabilities? Because, I found it to be almost backwards to be making decisions on most people versus looking at the harm that it could be caused to those who aren't most people. And I felt like I was being sacrificed. Like the subtext of the CDC statements might have, well has been, we have to move on. And if you die, that's unfortunate, but most people will be okay. I'm curious what your thoughts
are. You share my feeling of being quite both surprised and deeply disappointed in that, because not only did it tell me that the CDC was sending a message that our patients didn't matter, it additionally was sending the message that healthcare workers didn't matter. And so this idea that we should come in and even while we're ill and then take care of our patients, such as I take care of transplant patients. I don't want my patients to get sick because I was asked to come to work, say, inappropriately. So I completely share your sentiment, and I don't understand. I understand that hospitals are understaffed, but the solution to that is to abuse healthcare workers into working when they're sick and lead those healthcare workers to then physically injure their patients with a preventable illness.
And so are these folks at the CDC, are they I hate to use the word beholden because I don't like that word, but for lack of a better term, beholden to the same principles of bioethics as practicing physicians like yourself?
Well, there's public health ethics is an incredibly deep and rich aspect of medical care, as well as participating in a public society. And I think that I would like to believe that the folks who are working at the CDC who are making these recommendations are doing the best with the information they have, with the various pressures that they are experiencing from throughout the country. Certainly, I would expect people from the CDC to also feel compelled to have moral and ethical standards about the way that they make recommendations. I also understand that in this pandemic, we've seen some gaps. We've seen some decisions that we said, well, yeah, those didn't make sense. We got to roll it back. We got to come back to that and with a better position.
Now, because care isn't the same everywhere, and I think I'm a good example of that. How do we make sense of providers who are treating this disease so cavalierly, like in Florida or in Texas, where I heard in one case that there are providers that are giving out ivermectin, and I understand that as I understood it, that the hospital has sort of had their funding yanked as a result of some of this stuff. But how do we make sense of that? How do patients make sense of that? Me as a California resident, I'm getting great doctors. And some of the folks down in Texas aren't getting great doctors, and we're all dealing with the same problem.
I think one of the things that's really valuable in this conversation is realizing, again, one of the things that Dr. Needle had said, physicians are physicians are human beings too. And so physicians can also be kind of pulled in to conspiracy theories, to misinformation, to disinformation. And that's the best I can make sense of what's going on. Is we've seen an incredible political divide. You can really tell where folks are getting their information. We can tell, there are these disinformation spreading, for example, information about ivermectin that is presented with a veneer of authenticity. And I know that when I have even gone to look at those sites to really try to understand, like, what is leading doctors to write these prescriptions that just don't seem to make any sense, the information is presented in a way that knows how to hit those buttons of somebody who has the training that we have. And so unless you're doing a very careful reading of the information and incredibly critical of that information, I can understand how a physician could say, oh, I just go ahead and take this information and take it as is, and I'm going to go ahead and write you those ivermectin prescriptions and feel good about it.
Is there anything else that folks should know from your perspective?
I think the misinformation issue is the hardest to handle, and I think it's everywhere, and I think it takes so much more effort as an individual in society right now to figure out, am I getting accurate information? Is this source reliable? So I think what you're doing on this program is incredibly valuable. I think people need to be thinking about, what is my local newspaper? Money come that funds that newspaper? How is it that might influence the information that I'm getting? And I just want to have a sense of, can I get accurate information? And if something seems either too good to be true or too strange to be true, do a little more digging. Try to reach out to folks who may have better information, and really try to think about, am I getting this from a reliable source? Unfortunately, it is a lot more than it used to be to get that accurate information. So I urge those folks out in the public to do their best.
Dr. Alyssa Burgart, she is a board-certified pediatric anesthesiologist and bioethicist, got it right the second time, at Stanford University. And I want to thank you for taking the time, and I do hope that you will come back and see us again.
Thank you for having me.
Thank you. My third guest is not a doctor, although he does have a doctorate. His name is Ryan Sellers, and he is an attorney, a Texas attorney, and I would like to welcome to the program Ryan.
Hi, thanks for having me.
It's great to have you here. So you had an opportunity to listen to two physicians talk, and I love it when doctors and lawyers, get to listen to each other speak. And so I'm curious, what are some thoughts that you might have about what you heard?
Well, I found it very interesting, and I'm not a doctor, and my specialty is not the human body, but I know a little bit. And some of what we talked about wasn't directly relating to that. What I found most notable was that so much of the conflict resolution and so much of getting these things done deals with communication with the patient, between the physician's team and the patient. Both doctors, Needle and Burgart, both discussed, the importance of having a communication with this patient. But some of these patients are people that believe that this virus is going to make objects stick to their body. And in order to get to an understanding where the patient and the doctor both have the same understanding of the issue, there's a gulf there. There's a gulf that's created by this world of disinformation. And as you're just talking about, this information is such a powerful and incredible force that doctors are buying into it. I mean, it's a virus of a whole different kind. It's a viral virus of misinformation. So it's truly a unique and challenging problem that we're facing, and that these doctors are facing.
Well, now you practice in what I would call probate court back where I come from in New England, where you litigate issues related to wills, trusts, and guardianships, among other things. Is that right?
That's right.
And you are both an attorney and an attorney ad litem. What's the difference between those two things?
Okay, so an attorney is someone who practices law in any general area. However, in Texas, if you want to practice law in guardianship, or what's referred to in some states like California as conservatorship, then you need an extra certificate in addition to having a law license. I have that certificate. It's called an attorney ad litem. And the word comes from whenever somebody has a guardianship opened or an estate without a will. The court's going to appoint an attorney ad litem onto the case that represents, in the case of a guardianship, the proposed ward, or in the case of an heir, the potential missing and omitted heirs. That's where the phrase comes from. But to put it simple, I work in guardianship law. Attorneys that work in guardianship law have a certificate, in addition to a law license.
Now, I have this burning question, and I'm gonna babble for a bit here. But one of the areas I practiced in was in guardianship law, among other areas, and I can still hear the judge's voice saying that you can decide to decline medical care if it was a knowing, voluntary, and intelligent decision. And I remember having cases where there were people dying of cancer, and the hospital or the family member were seeking guardianship because the patient or the proposed ward wanted to stop treatment because they were going to die and the likelihood of survival was slim to none, and they had come to terms with that. And it was painful and it was horrible and it was debilitating what they were going through. And I remember the court saying that the decision wasn't knowing and intelligent, that any reasonable person would want to do everything that they could to survive. And so fast forward, I am hearing and watching people make inane statements about why they're refusing to be vaccinated. People, as you mentioned, who think that metal spoons will stick to the side of their face, that there's a microchip being injected into their body with a tracker as they grip their iPhone with a geolocator in it, and that operates off of a pinging system to argue with me on Facebook, that they think it will alter their DNA. And I guess I'm trying to understand how these folks aren't in need of someone to look out for their best interests when there's a disease spreading that can kill them and is killing them, and it's breaking our healthcare system. I mean, a vaccine isn't a debilitating chemotherapy, but we can't seem to compel vaccination, and there doesn't seem to be any interventions going on. What are your thoughts about that?
I have a few thoughts about this. So let's talk about the first situation, the cancer patient who wants to refuse treatment. There are situations where a court will appoint a guardian to make that person go forward with their treatment. I think that those are rare, but it does come up from time to time. Comparing that to somebody's refusal to take a vaccine, I see several distinctions. That if we're going to talk about this honestly and say, yes, this is a situation where somebody's making a decision that's potentially very harmful, and the science absolutely says that. Yes, we can have a doctor say that failing to get a vaccine or refusing a vaccine is damaging, harmful to your health. But you know what? There's plenty of people that go and drive 30 miles over the speed limit without a seatbelt every day, and we don't put them under guardianship. And there's people that refuse to do other things. And another distinction is that the vaccine is prophylactic. It's trying to get ahead of the problem. You aren't sick yet. There is the possibility that you don't get sick despite not being vaccinated. I understand that that's not a good approach, and I agree that that's not a good approach. But if you're going to compel a judge to take somebody's rights to make their own decisions away, I think that the closest you get is the cancer treatment, and it's not going to go into things like vaccination. I don't expect that the law will provide for guardianships in that.
Now, at the other end of the spectrum, I also practice in abuse and neglect law, and parents who didn't provide the appropriate medical care for their kids were often charged with neglect. It was civil, not always criminal. And many times they had their children taken away from them. Now, that's not your area of law per se, but in one case, children can be removed from care, and having to be able to take care of your child is a federal and state right. Those are usually it's certainly a constitutional right, and so I guess I'm trying to understand, why it's okay for the courts to act in the case of a prophylactic for children, but it's not okay for the courts to act for a prophylactic that has been demonstrated to reduce the severity of the disease for most people, and to keep them from having to have the ICU care.
Well, it might be more of a practical and political question that is the issue here, because even if we could say that everybody would be better off if we just forced everybody to get vaccinated, because of the disinformation, the fallout and backlash to that would be something that we just wouldn't be able to cope with.
Now, what are the conditions for which a guardianship is warranted?
Well, you need to, in Texas, you need to explore less restrictive alternatives. So in the instance of financial abuse, we need to see if somebody has a power of attorney that can go and take action on behalf of somebody before we go and create a guardianship. We need to see if we can use supports and services and assisted decision-making before we can create a guardianship. But if somebody is, being harmed, financially abused, and basically requires the law to step in for their own well-being, whether physical or financial or whatever it may be, then the guardianship is there to do that. But the biggest and the thing that we learn most whenever we learn about how to practice guardianship is the alternatives, because guardianship is such an extreme measure to take somebody's rights away as an adult without them having committed any crime, simply for the fact that they will be harmed if it's not done. It's a really extreme measure to take.
Now, you heard Dr. Needle talk about end-of-life care. What are some tools that are available to folks to have them express what they want when the time comes?
Physician's directive is your go-to. That's going to tell the doctors that if you're in a condition that is going to be vegetative and you're not going to be able to be resuscitated and you're going to be stuck, let me be comfortable or let me die, whatever you need to happen. And then there's, of course, power of attorney. You're gonna designate someone to make the decision for you. I don't know, because you don't know everything that's going to happen. You don't know. You're never expecting that car wreck. You don't know what's coming. So what you need is someone else you could trust to make the right decision for you if that time comes. And
I want to be careful to say that in states, every state is a little bit different and a little unique in the way that it handles its laws. Some states call that an advance directive. And so, you want to make sure that you check things out before, so that you know what your options are. But do you need to spend a lot of money on a lawyer to take advantage of those tools, or is that something a hospital can offer you?
A hospital can offer those, yes. And I offer them for free with my firm. I mean, a lot of attorneys don't mind helping you fill out a form if you just want to walk through their office. It gives the opportunity to try to sell you something else, right? So, but I mean, yeah.
You're an honest lawyer, huh?
No, but I mean, it's something that everyone should have done. If you don't have the money to go get a will, call somebody, go to the hospital and get a physician's directive, medical power of attorney. It's better to have it and not need it than need it and not have it.
Now, we know what an advance directive is, and we've heard about bioethics committees. This isn't sort of a legal question. This is sort of two lawyers sort of bouncing the ideas around. But do you have any thoughts on how the conflict should be resolved if the bioethics committee is coming back with a recommendation for X and somebody with an advance directive has articulated Y on their advance directive?
Yes, the previous guests, the Dr. Needle and Dr. Berger, they really emphasize that is the situation where there is two people in one ventilator is very rare. And so we should take any conversation appreciating that. But at the same time, it happened at least once. And for somebody like you to know that happened once, it has to be pretty, I mean, that would bother me. Because it's not your fault you have asthma. You didn't choose that. But at the end of the day, some doctor might look at that and look at somebody next to you and say, I'm sorry, Dr. Tracy, but if we don't give the other person the ventilator, the most likely outcome is you're both just going to die. So, I mean, that's terrifying because it did happen once. So, I mean, part of being an attorney is thinking about, okay, well, I don't just deal with the common situation. I deal with the rare situation, the one that's really far out there. At the end of the day, I don't think that hospitals are going to be liable for making a smart decision and a well-advised decision as long as they're taking into consideration all of the relevant factors. So yes, these ethics committees, and it sounds like they're doing an upstanding job, but they need the thing is they don't want to come to a recommendation without all the information. So I think as long as they're being diligent in their assessment, then they're making the right decisions. And I don't think that they're going to be in legal trouble for making these very tough but necessary decisions.
Now, another piece hanging out there is the cost of care for folks who haven't been vaccinated. What's the duty of a health insurance company to pay for that care?
Well, people like to say they did their own research. I'm going to tell you who's going to do their own research. Health insurance companies are doing their own research. There are already workers that are paying more because they aren't vaccinated. I don't think that it's going to be in the way of a penalty. I think rates will go up and people who are vaccinated will get a discount. But in any way you cut it, I think that we're headed to a world where people who refuse to get the COVID vaccine are going to have higher insurance rates than people who got the vaccine.
And is that in spite of the ACA, where they can't take into consideration of, they can't consider prior conditions? Or do you think that'll change?
I do think I think it's going to change. I looked at an article just before this where some workers had been finding some companies had been finding a way to where their workers were paying more. And
I'm familiar with that. I'm familiar with that. What they were doing is hiking up the premium end of it.
Yes.
And if people are self-insured, then that helps recoup those costs.
Yeah, and that's where I think the costs are going to go up, is the premiums.
Now, what are your thoughts about the potential for beneficiaries to a will or trust contesting the costs associated with last illness? Because they're going to be a waste on the estate when those costs wouldn't have been exorbitant but for the failure to vaccinate. Do you think that's a possibility?
This is going to be something that's going to vary state to state, but in Texas, pretty much always your last illness is going to be paid out of the estate if there's money for that. So you're talking about somebody who actually has money in the estate. The last illness is the class 1 creditor in a long list of classes that's going to get paid out of that, along with burial expenses. Everybody's going to have their last illness paid for if there's money, and then everybody's going to have that. I don't think that the vaccination is going to change that very straightforward and reliable system in Texas. I couldn't speak to other states.
Thank you. Texas Attorney Ryan Sellers, he's at Hale and Sellers, if I recall correctly.
Yes.
And, as I understand it, he'll help you out with your power of attorney and your advance directives. So if you're in Texas, you might want to give him a buzz. Thank you so much for being here. And I do hope that you'll come back again so that we can talk about this some more.
Absolutely. Thank you so much for having me.
Thank you. Oh, my goodness. So that was a lot of information, folks. Despite that, I still sort of feel like we're in trouble, and we need to turn this around. I mean, we've heard about a lot of different things tonight, a lot of different gaps and places where, we're still not doing everything that we can. Doctors used to be relied on to help us, and now they aren't trusted. Scientific data is real. It's about as real as it gets. It's reliable, it's valid, it can be reproduced, it's built on over time as we learn more. And doctors spend years of their lives learning the intricacies of the human body, not just from books, but hands-on. Yet we think we know better by Googling answers from public websites that don't meet the rigorous standards of peer review. There isn't a single ethical doctor who doesn't fall apart when they lose a patient. There isn't a doctor that's going, oh, well. These doctors and nurses have been surviving in such horrible conditions for so long that we're losing the very people that we need to be able to survive this crisis. It doesn't matter how many hospitals or ventilators or rooms you have if you don't have the staff to do their job. But our refusal to take care of ourselves, our refusal to heed the warnings to do the right things, and then end up in a hospital where heroic measures need to be taken to try to save our lives is driving these people out of their vocation. And it is a vocation. I heard 2 doctors tonight speak very passionately about the work that they do. They spend years studying, and they enter residencies and fellowships and continue their study. Medicine is a lifelong vocation. And then people get litigious over the fact that their loved one isn't going to survive when they didn't do the thing that needed to be done to make sure that they were in the best position possible to stay healthy. I understand human nature. I was a practicing lawyer for almost 20 years. I was a mediator, investigator. I understand human nature. I understand denial. If I deny it, it's not real. If I rationalize it, I can manage the fear. If I call it something else, it won't seem that bad. If I put myself in the same category as someone who survived it, even though I have complicating factors that would likely lead me to probably die of the same disease, then at least I can be less afraid. If I blame the journalists for reporting on facts, I can frame the issue as fear-mongering. If I frame the issues in terms of freedom, then I can justify my choices. If you want to live in a frame that's about personal freedom, then you need to understand that with freedom comes responsibility. It's often said that freedom is not free. Indeed. We have a personal responsibility to do whatever we can to stay healthy. We have a personal responsibility to do whatever we can to make sure other people are not made sick by our choices. If you don't want to get the vaccine, stay home. Don't make me stay home. If you don't want to wear a mask, stay home. Don't make me stay home. If you don't want to wear a mask, don't harass me because I need to. If I get this disease, I'll die. There are people standing on street corners harassing people wearing masks. There are parents of kids harassing children at school bus stops for wearing masks. There are parents accusing government officials of abuse for requiring masks. Get a break. Just seriously, get a grip. I worked in abuse and neglect law. I represented parents, among other areas of law that I worked in. And I got to tell you, it's neglect to not get your child vaccinated if it will keep them from getting a serious disease and dying. And the state departments of child welfare should be doing something about that. So if you're watching, any of you in child welfare law, you should be doing something about that, because you had absolutely no problem taking kids away from my clients, okay, who had done far less. Your freedom is not free. Your parents and your grandparents did what they need to do to be safe. That's why you're alive and walking and in all likelihood don't have polio. We have a responsibility to ourselves to have advanced directives that guide our families and our providers when we aren't able to advocate for ourselves. There are absolutely bad doctors. There are unethical doctors manufacturing fake vaccine cards, prescribing and administering a horse antifungal that doesn't work on a virus. And I want to be clear here. A fungus is not a virus, okay? An antifungal won't kill a virus. In fact, it'll disrupt your system and the flora of your body and make it harder. If you're at all in doubt about that, ask any woman who's had to take antibiotics and she'll tell you why. We have a responsibility to be educated. Every week I get to do this show and I think, what an incredible gig. I have the ability to talk to extraordinary professionals who can answer questions and provide context to understand the nuances of what my colleagues in the news are reporting on. I get to bring you that information. I want to again thank our guests, Dr. Jennifer Needle, Dr. Alyssa Burgart, and Attorney Ryan Sellers, for sharing their expertise with us. I want to thank you for joining me this evening, and I look forward to seeing you next week. Until then, I wish you a good night and a great tomorrow. Stay healthy, mask up, get vaccinated, and get boosted.